What's the number one challenge in the field of psychiatry that has held us back from achieving what has been achieved with such great success in oncology, cardiology, and GI medicine? The answer is those fields can biopsy the organ of illness. So one of the things I'm excited about is to develop a proxy for a brain biopsy.
Welcome to Insights on Psychiatry. I'm Dr. Leonard Adler, the Potash Professor of Psychiatry and Director of the Adult ADHD Program here in the Department of Psychiatry at the NYU Grossman School of Medicine. It's my pleasure today to be speaking with my chair, Dr. Charles Marmar, the Shue Professor of Psychiatry and Director for the Center for Precision Psychiatry in the Study of Alcohol Use Disorders and Stress Disorders. Charlie, it's a pleasure to be talking with you.
Pleasure to have a conversation with you.
Today, I wanted to go over your general sense of PTSD and how we treat it and the types of patients you see. You're an internationally renowned expert in PTSD. Is there one type of patient with PTSD?
I think our current research, supported by a now nearly 18-year collaboration of 6 academic medical centers and the Army's elite molecular biology lab at Walter Reed, colleagues at Harvard and UCSF and Institute for Systems Biology and elsewhere, suggest that there are multiple subtypes of PTSD. In the same way that there's not one kind of depression, we have unipolar and bipolar depression. We have typical and atypical depression. We have more endogenous biological and more situationally reactive forms of depression and other subtypes. There are probably at least 4 or 5 major subtypes of PTSD. The ones we've been studying and the ones for which we have the best evidence so far are the following. A simpler form of PTSD, often following a single traumatic, stressful life event, like an accident or a natural disaster, and someone who was previously psychiatrically and medically healthy. And they tend to develop a very resilient person who's deployed to a war zone, comes out of a war zone, experiences some period of being on guard and vigilant because they've come out of great danger, and then quickly accommodates to that. We call that simple or subthreshold PTSD. It usually lasts weeks to months and often spontaneously recovers without treatment, but may require some brief intervention. At the other end of the spectrum is a very complex, very severe, and often very comorbid form of PTSD. It's been called complex PTSD or PTSD with co-occurring problems, and it usually occurs in people who've had very difficult lives, who've been repeatedly exposed to adversity through childhood, sexual abuse, physical abuse, emotional neglect, and repeated trauma exposure, who then experience subsequent adolescent and adult trauma. For example, a warfighter who's been deployed on multiple tours of duty to Vietnam or Iraq and Afghanistan or elsewhere in the world, who had very difficult childhood and may have chosen to go into the military because they came from a stressed and disadvantaged background and are looking for some structure and safety in their life, and then end up getting very heavy combat exposure. And in between those, there are subtypes with PTSD with severe depression and subtypes of PTSD with major cognitive impairment. So at least 4 simple, very complex and severe depressive subtype, cognitive subtype, and maybe a dissociative subtype. Those are the 5 best well-established ones.
What kind of research are you doing now that you think will have the greatest impact?
We have a number of ongoing projects. a heavy focus is on precision medicine and alcohol use disorder with and without stress disorders. And there what we're doing is we're conducting clinical trials with novel treatments for alcohol use disorder. For example, gabapentin, which is an anticonvulsant drug which is effective for alcohol use disorder. And we are studying DNA and RNA and other molecular features in each patient to see which molecular pathways are dysregulated and which ones predict if you will or will not respond to that treatment. So we're doing genomically informed precision psychiatry trials. We're developing subtypes of PTSD and looking which molecular pathways and brain circuits are dysregulated in which way in the different subtypes. We are planning a new project to study the novel weight loss drug, tirzepatide, or one of the other GLP-1 agonists, which are anti-craving, to see if they're effective in alcohol use disorder, and if so, for whom, by studying their genomic variants as well as their imaging patterns. We are developing a very interesting project, Len, to try to address one of the, if I were to say, what's the number one challenge in the field of psychiatry that has held us back from achieving what has been achieved with such great success in oncology, cardiology, and GI medicine? The answer is those fields can biopsy the organ of illness, and they can then study at the single cell level what the deep nature of the pathology is. We know that the amygdala is dysregulated in PTSD and ADHD, but you and I are studying those problems, but we cannot biopsy the amygdala in our living patients. So we are very handicapped in our ability to know precisely what is the nature of the amygdalar dysregulation. So one of the things I'm excited about is to develop a proxy for a brain biopsy. How do we do that? We study little vesicles called exosomes that are released from neurons in the brain, pass through the blood-brain barrier, and we study them in blood so we can access them to see what's the molecular cargo that's actually dysregulated in our patients. And we can even know where in the brain some of those exosomes came from, the hippocampus, or even the hypothalamus, the hippocampus, let's say in the case of the hippocampus, which region, the dentate gyrus of the hippocampus. So we can study exosomes. We can study from brain banks from people who have generously agreed to donate their brain to science when they pass away. We can study molecular pathways and do single-cell genomics in those brain bank specimens. We can harvest peripheral blood cells, reprogram them back to stem cells, and program them forward to create brain organoids, which can reconstruct features of the human brain at an individualized level in a given subject. So, for example, in the topiramate study for AUD and PTSD that we're just completing, where we have a NIH grant pending to grow out brain organelles in those patients who did and did not respond to topiramate, and then we can study those organelles and even challenge those organelles with topiramate to try to understand those differences. The idea would be to triangulate peripheral blood markers, exosomal markers, molecular features from postmortem studies, molecular pathways in brain organelles, and other approaches so that we could approximate a brain biopsy. And I could just finish briefly by saying, as a proof of concept of this, we published a paper, so this I can talk about. It's in the public domain. We at NYU, Psychiatry and Neurology collaborated on the care of a patient who was completely refractory to all treatments for depression. They had had electroconvulsive therapy, they'd had many medications, many psychotherapies, and other treatments with no benefit over several decades. Concern was raised by neurology that they might have a rare brain disorder which would warrant a brain biopsy. Their brain was biopsied in a silent area in their prefrontal cortex using surgical technique safely. There were no side effects from the biopsy. The biopsy was sent to neuropathology, and it was found the patient's brain, at least in the prefrontal cortex, had massive invasion of inflammatory cells. We gave that patient a novel anti-inflammatory drug, infliximab, that crossed the blood-brain barrier, and for the first time in decades, that patient experienced reduction of their depression symptoms. One biopsy, no side effects from it. And you have to also ask, what were the cumulative effects of all the other treatments on their brain and on their life? Obviously, living with severe depression for 20 years would be tremendously disrupt a person's life. So while we can't routinely biopsy the brain, if we can develop a proxy for it, that single case provides a proof of concept that we could eventually personalize treatment.
So, Charlie, really the future is bright, and really it's all about trying to get the right treatments for the right patient.
It's all about finding out what's the deep problem that we're trying to solve, and then personalizing treatment in relationship to that problem. Let's summarize this way. When you or I were in training, how did we treat breast cancer and prostate cancer? One size fits all, fundamentally. They got some combination of radiation, surgery, and chemotherapy, or all of them, and you did the best they can. Now we can treat those disorders in a personalized way with monoclonal antibodies that target their variant of their cancer. I would hope in the future that you and I could collaborate on the care of a warfighter with very complex PTSD and ADHD and know which molecular and circuit pathways are disrupted and which treatments would help that individual person.
Well, it's been a pleasure talking with you, Charlie, and it's really been exciting to talk about all the new things that are coming.
Thanks. I enjoyed speaking with you.